Thank you, Dion. It's a great honor to be here talking on behalf of our core study group. I will try to give you an introduction of the job we did in these last 3 years and to begin this symposium. I have no conflict of interest. So our group was born 4 years ago. It was a small group of young surgeons, ESCP members from 5 different countries. This was the start group. Now it's a little bit changed, but not so much. And we gathered together to organize snapshot study. So the first question was, what's a snapshot study? It's pretty good name, but what is it really? It's a multi-center study with multiple hospitals in a short period of time. It's prospective and it's observational. What does it mean? It's an audit. That means that the patient will follow the normal pathways in diagnosis and treatment. There are no additional visits, and local investigator can be more proactive and vigilant about the patients. What is it for? It's a good method to explore difference in patients, in technique, in management of the patients, and that's really useful to identify areas of variability in the daily practice, and that could be can result in apparent difference in the outcome. That's important to generate hypotheses and to identify areas for further research in the future. But probably one of the most important things is to build a strong research network. And to do this, our authorship policy was from the beginning to publish all the articles deriving from these studies as a collaboration group, and each center could identify up to 5 investigators to be included as an author in the different papers. So the second question was, what do you want to study? So this guy is a surgeon. It's 2 a.m. in the morning. He's really tired because he has operated all day long, but he cannot sleep. He cannot sleep because he's thinking about that 8-year-old patient he is operating, about the specimen, the cancer is resected, but most of all, he's thinking about anastomosis. And he's thinking about anastomosis because his sixth sense is telling him that probably that patient is going to have an anastomotic leak, and he cannot sleep. So there are some colleagues that study this sixth sense feeling, and the good news is that it doesn't work. So when the surgeon thinks he's going to have an anastomotic leak, that's not true. It's like a flip a coin. So our colleague can sleep quiet and have sweet dreams. But we're still at the same point. Why is it important to determine the risk factors for an anastomotic leak? And the most important thing is to correctly avoid the risk factor, to decrease the anastomotic leak rate. In patients that are at high risk, probably we can decide to do a stoma. And obviously in these patients, we must perform a strict follow-up trying to diagnose the leak early. So the first snapshot study we did in 2015, we decided to do it about right colectomy. Why did we choose this with this technique? It's easy. It was our first snapshot, so we wanted something really common that could be done in all the hospitals. It's really no specialists. There are many general surgeons doing right colectomies, and all the hospitals do and perform right colectomy in a reasonable numbers. We calculate more or less more than 80,000 right colectomy in Europe per year. So when we talk about right colectomy, the first thing we have in mind is the endless battle between stapler anastomosis and Hansen anastomosis. I imagine that in each center, in each hospital, there is this ongoing battle continuously. So the main question we did is, does anastomotic technique impacts upon the postoperative outcomes and anastomotic leak rate after right colectomy. The data collection period was a 2-month period in early 2015. Follow-up was for 30 days, and we had an online secure database to record the data. I'm going to talk about the results, the participants to the study. This was, I think, the most important result of our first snapshot. It was absolutely astonishing. We were really happy with this. These are the co-investigators that participate to the first snapshot. I think we have no time to mention all of them, but they are all detailed in the first paper we published in colorectal disease. You can find it downstairs in the Willy stand. More than 1,000 different surgeons participated to the snapshot in more than 280 centers in 38 countries, and more than 3,000 patients were introduced in the database. This is a detail of participation per country, great participation in Spain, Italy, Holland, Belgium, UK. And one thing we were very happy with, it was the high quality of data we collected. More than 97% of the patients had a complete data set, and that's really important. These are the most important results. As you can see, we found out that anastomotic leak, also in right colectomy, but we think it's an easy operation, it's a major problem. More than 8% of the patients had anastomotic leak in our study. And why this is a problem? It's a problem because mortality is absolutely correlated with anastomotic leak. More than 10% of our patients with anastomotic leak will die for this complication. Another interesting finding of this first snapshot is the absolutely important variability between the different countries. This is the anastomotic leak rate between the most involved country. As you can see, there are some countries with 0% anastomotic leak, and some other countries with up to 13% of anastomotic leak. It would be very interesting to explore this difference. When we perform a multivariate analysis trying to find anastomotic leak risk factors, we found out 3 different variables. The mechanical anastomosis, the open surgery, and anastomosis performed by a general surgeon. But as I told you, this study is important to make new questions and to find a field for future research. So these were the questions we had. It's open surgery real risk factor, or is the patient selection that gave us this result? And it's the general surgeon. It depends on the experience or on the training. Maybe we can improve this risk factor. And what about the mechanical anastomosis? What's the problem here? It's a multifactorial problem. Is the technique, probably the surgeon doesn't use the machine as it should be, or it's the machine? So as you see, a lot of questions we have still to answer. These are the 2 first papers we published. Both of them, as you can see, there is no first author. It's a collaborative authorship. And the following year, 2016, we launched the second snapshot study. It was about the closure of intestinal stoma. It was coordinated by Dr. Oded Samora. We included all patients with closure of any intestinal stoma, ileostomy, colostomy, and ileostomy and colostomy, everything. The participation improved. It was already incredible in the first snapshot. It was better in the second. More than 1,200 participating surgeons, 300 centers in 48 countries, 2,500 patients entered. As you can see, it's not a Europe map no more. It's a world map. We have patients from outside Europe introducing a lot of patients. And these are some of the results. Type of stoma, as I told you, we included both ileostomy and colostomy, and any stoma configuration. Anastomotic leak, obviously, was different in the different kind of stoma. It was 4% for loop ileostomy, it was up to 8% in the closure of end colostomy. This is the time of creation of the stoma. Most of them were done during the primary surgery, but 15% was a consequence of a complication of anastomotic leak. Time of from creation to closure of a stoma was close to 6 months. Most of them half of them were stapled and half were ensewn. And this is the anastomotic leak. As you can see, it was not a very frequent complication, but we didn't find any difference between ensewn, closure of the stoma, and stepped technique. So the resume of this second snapshot, we're still analyzing data, was that the majority of these stoma were created during the initial procedure, and the closure was half by stapler technique and half by ensewn, without any significant difference in the outcome. This year, we performed a third snapshot study, and so far we have more than 10,000 patients introduced in these 3 studies. This is absolutely a gold mine to analyze, and colleagues in the next minutes, in the second minutes, will talk about it. So what's the message? We identified with this snapshot important points and issues that could be really important for future randomized controlled trial. Most importantly, collaborative research really works. We and you formed a really strong network for future study, and I think that altogether we can really achieve great results for our patients and help them in their disease. Thank you very much.